Okay, good morning to everyone. Thank you so much for the invitation to be here. It's really my pleasure to give this talk, Approach to the Treatment of Invasive Aspergillosis. I do have a couple disclosures. I've done consulting for a number of companies involved with aspergillosis, both diagnostics and treatments. Those are listed here. We have substantial research support from several of these companies as well. And in the past, I've served as the data monitoring safety board for Pfizer for an unrelated non-fungal diseases project. The key topics to review today are really a large, big picture overview of invasive aspergillosis. So we're going to talk about the changing epidemiology of this disease, and some of the other talks are going to focus on that as well within the intensive care unit. Talk about diagnostics. There's numerous diagnostics. There's a number of new diagnostics available. Depending on where you practice, each center seems to have a little bit different flavor for how they diagnose and approach invasive aspergillosis. Susceptibility testing and resistance, that's really essential to talk through, and we'll go through that over a number of different slides. That has a huge impact on our treatment and the duration of therapy for these patients. And then what really are the first-line treatment agents for invasive disease? Prophylaxis is another topic we're going to need to talk about, and then the approach to so-called breakthrough infections. So that's patients already receiving antifungals. If they break through and have an infection anyway, how do we approach those patients as well? So we're going to start with the epidemiology and the associated mortality of invasive aspergillosis. And this is a little bit of a busy slide, but I think it's really important because it shows the total burden of fungal diseases across the globe. So you can see on the left side here that starts really with more of a syndromic, not Aspergillus, but these are skin, hair, and nail infections. You can see there's almost 1 billion of those fungal diseases per year. And as we move to the right, we see other important things like fungal sinusitis, ABPA, allergic bronchopulmonary aspergillosis associated with asthma, and then chronic forms of aspergillosis, which are not a focus of today's talk, but are still really an important entity. And then on the right side of this slide, you can see invasive aspergillosis, and that's circled there with a red box. There's about 300,000 global cases a year, and that's a tremendous burden on the healthcare system. The disease often gets in the way of effective chemotherapy. So if a patient has leukemia or recent transplant, develops invasive aspergillosis, it's really going to slow down the course of their treatment. They're going to have control of their aspergillosis before we can proceed to the next round of chemotherapy, et cetera. So a tremendous problem in the treatment of these patients. Unfortunately, we're also seeing more and more cases of Aspergillus yearly. That's for a number of different reasons. We think the primary reason, though, and there's a really nice paper in JAMA that outlines this from just 2 years ago, that shows the increasing number of immunosuppressed patients globally. It's about 8% of all adults, particularly in China and the United States, et cetera, that are thought to be immunosuppressed. They're on some biologic agent that knocks down their immune system. They've received chemotherapy, transplant, et cetera. So the growing number of patients at risk for Aspergillus also continues to increase. This is going to be a bigger and bigger problem going forward. And then why do we care? So this slide really shows the problem with these different fungal pathogens. You can see even Candida or Candidemia, bloodstream infections from Candida, which is not the focus of this talk, but even that, which is most of the time fairly straightforward to treat, has a 30% overall associated mortality. And if you look down one more line, you can see Aspergillus. The mortality associated with that is between 50 and 60%. Down to invasive molds that are often resistant, things like Fusarium, Mucorales. Those are very driven by host factors and the host immune response, but have an associated mortality of 50 to 80%. And then resistant fungi, which are not the focus of this talk, but certainly important to recognize, things like Scedosporium, Lamentaspora, mortality often over 90%. But you can see on the right side here, this was a large data study that some colleagues and I wrote just a couple of years ago. We wanted to see what's the real world outcomes with mortality associated with Aspergillus. So not in a clinical trial setting, but this is, a pool of hospitals from across about half of the United States. And what are the mortality rates at 1 year? And you can see what that looks like at the top. That dark blue line is the overall associated mortality from invasive Aspergillus, and it's about 25%, so a little better than the figure on the left. But as you look down through the different forms, you can see several of these have very high associated mortality rates. So solid malignancy tends to do the best. They also don't have as much Aspergillus. And then as you go to acute myelogenous leukemia there in yellow, you can see their mortality rate's about 50% at a year. Aplastic anemia does even worse with again, about 50 to 55%. And then those with Kappa, COVID-associated Aspergillus, which is going to be a different talk today in the ICU, have the highest associated mortality from all of this. And it doesn't mean it's attributable to Aspergillus, but that's their 1-year outcomes. And you can see it really starts to plateau about 100 days. So those patients are very sick up front. And then we have to, of course, follow them and get them on appropriate treatment. So even with advances in diagnostics and treatment, we still see a lot of associated mortality with invasive aspergillosis. So who is at risk? So I think that there's some traditional risk factors for aspergillosis, and that's what most of us learned in medical school. These are the things that we've heard about for years. And just to review those very quickly, are patients with quantitative or qualitative neutrophil defects. So neutropenia, of course, remains the major driver of aspergillus. Chronic granulomatous disease, we strangely have seen more of those cases recently. I think partly because we're looking for it more often. We've even seen that in some older patients in their 40s and 50s, which is quite different from how it's traditionally taught, where we see that in kids and teenagers. Also, T-cell deficits and inhibition. This is a big focus with transplantation, advances in transplant therapy. Corticosteroids are given to an increasing number of patients, and then other medications. And with that, the Infectious Diseases Society of America has put together a guidance document that's going to be published later this year, and it's focused on the biologics, so TNF-alpha blockers, some of the new oncology medications, and what is their risk for mold infections, for yeast infections, et cetera. There's some surprises in that data. There's several hundred of those different medications now, but we did see mold infections with several of these new biologic agents, unfortunately, and I'll talk about those in one of the slides. Allogeneic stem cell transplants, particularly those with graft versus host disease, those patients are immunosuppressed for long periods of time. They accumulate risk over the duration of their immunosuppression. And then again, the ICU, and not just COVID, but severe influenza and even severe RSV, respiratory syncytial virus infection. Even those viruses have been associated with aspergillosis. So this is a very busy slide, and we're not going to go through all this in detail, but I just wanted to compare the previous slide, which is how we're traditionally taught to think about risk factors for aspergillus, versus this is what really happens in real life. And patients have a variable risk over the duration of their illness. So you can see at the very top here, we can go through a patient with acute malignancy or with low white blood cell count, and their risk is really going to change over the course of their therapy. So if you look down in the green, sort of in the middle for solid tumors, those are fairly low risk, so they remain in the green. And then if you look down sort of at the bottom, some of these patients have a course that is red and very high risk for acquiring aspergillus. And then with different forms of chemotherapy later in their treatment, they return to green. So it's really important not to try to put all of these patients into one category and think, well, they got chemotherapy, they're at risk for aspergillus. It really depends where they are in this course. So if, multiple myeloma, if they've gotten their upfront chemotherapy followed by CHOP or CHOP therapy, once they go to an auto transplant, they're actually at lower risk for invasive aspergillus. So it's really important to think and contextualize the flow of these patients over time. And if you're interested in this in a more detailed fashion, which we obviously don't have time for today, this was published in Open Forum Infectious Disease just about a year ago, and it's the Aspergillus guideline authors put this together, but we thought too complicated to put in the guidelines, the updated guidelines, which are not yet published. So we put this out just to really stir the conversation about risk and how risk is dynamic and changes over time. And then the one biologic agent I did want to talk about as a significant risk factor for invasive aspergillosis is ibrutinib. So ibrutinib is a tyrosine kinase inhibitor, but it has a lot of pleiotropic effects. There's a multitude of off-target effects with this agent. It's been really a breakthrough for CLL and other B-cell malignancies. It's also known to cause hypogammaglobulinemia, so lots of the patients receive IVIG during therapy with ibrutinib. But the frustrating part of this is an increasing number of patients initially were recognized with disseminated aspergillosis at the time of diagnosis. You can see in the bottom right here, a number of these different papers have shown a retrospective French study showed 33 cases of ibrutinib-associated aspergillus in CLL patients. And then in red, the really difficult part is 11 of 27 in a different study had CNS aspergillosis, and you can see that pictured at left here with multiple mass lesions within the brain, and those patients are going to really have a difficult time during their treatment. Those are going to have to be very aggressively treated. We know surgery is associated with improvements in mortality from a paper by Stefan Schwartz written in the past. So they're typically going to need surgery, a fairly long course of antifungal therapy before they can restart their chemotherapy. So really a difficult group to take care of. This has caused some centers to put patients on ibrutinib that have other risk factors, such as also receiving steroids for CNS lymphoma, etc., to put those patients on prophylaxis. That's a different group than is traditionally put on prophylaxis for Aspergillus in the guidelines and those sort of efforts. But this is a group to really pay attention to as your patients on ibrutinib, and to know your local epidemiology and the incidence of Aspergillus in this specific patient group. It's something that's not always looked at and caught by the cancer therapy group, this ibrutinib therapy subset. So all patients in these studies did have refractory or relapse disease, so they had accumulated risk over a long time. Again, received steroids, but again, a group to really pay attention to is those receiving ibrutinib therapy. Okay, so that's kind of the background, an update in epidemiology and risk factors, but we'll go on to diagnosis. And just to use a very quick illustrative case, I know you all have seen a lot of invasive aspergillus, but just to review the diagnostic criteria developed by the Mycosis Study Group and the European Confederation of Medical Mycology really puts forth that they need to fulfill 3 criteria to have what's known as probable disease. So proven disease is if we recover the organism or a biopsy and shows it, but probable disease is where most of our patients end up. We can't quite completely confirm the diagnosis, but they've got a host factor, like this patient was 12 weeks after allogeneic stem cell transplant, had graft versus host disease, and they're on chronic prednisone. They have a radiologic factor. You can see here's a classic CT scan finding. You see this consolidation or mass lesion in the left lung that has a surrounding halo sign, that area of angioinvasion surrounding the lesion. And then they have positive mycologic criteria, and that's a number of different things. A positive PCR test, positive galactomannan, cell-free DNA PCR is used very frequently now at some centers in the United States, hopefully elsewhere. But does this patient need additional non-invasive diagnostics? And should we do a biopsy of this and try to obtain the actual fungal organism so we can do susceptibility testing? So to review very quickly, just what is galactomannan, what is beta-glucan? These are the mainstays of diagnosis for most of our patients. And you can see here is a cross-section of the cell wall for Aspergillus fumigatus hyphae. You can see galactomannan in red there is just sort of a portion of those sugar moieties on the cell wall. Beta-glucan a little deeper, but both of those are detectable in multiple different sample types. We can detect those in the serum. We can detect that in BAL, bronchoalveolar lavage, and we can even detect that in other body sites, knee, synovial fluid, spinal fluid, and those with spinal aspergillosis or CNS aspergillus. So we can check other body sites for these specific diagnostic markers. The problem with these is the sensitivity and specificity really vary greatly by patient population. So the more neutropenic the patient, the better test galactomannan is. That said, a patient that's a solid organ transplant that's not neutropenic but heavily immunosuppressed by medications, it starts to lose its sensitivity quite a bit. So the more neutrophils, the less effective that test is. The BAL samples, the sensitivity is fairly low. You're going to catch a lot of colonization in the airways, and that can be difficult to differentiate from true infection. So it's important to think about using these tests with multiple tests used together. Beta-glucan, you can see again sensitivity and specificity outlined there in the middle, but very relatively poor sensitivity in some populations, and that's just because beta-glucan is present in so many things we do to our patients. Heavily filtered products, albumin, IVIG, all of those contain beta-glucan, and when administered to the patient can cause false positives. Also, a patient who's had a recent surgery, when they pack the abdomen with gauze, that can leach out. It's full of beta-glucan and can cause false positives. So just things to remember about beta-glucan testing. But some studies in the past have directly compared those to one another, the galactomannan versus a beta-glucan. And galactomannan does have a higher specificity, just like you would guess, but a lower sensitivity. So a lot of us use these together. We send both tests as well as an Aspergillus PCR. One of the things to really remember, though, is the very time-dependent sensitivity of bronchoalveolar lavage samples. So you can see it's very important to do this early. So if your hospital works like ours, and it seems like a lot of these patients come on a Friday afternoon, and if we have to call a colleague to do a BAL sampling, they often want to wait till Monday. And you can see on this graph why that's not a great idea. The diagnostic yield decreases substantially over time, between 5 and 10% per day that you wait to do the BAL. So it's probably one of the best tests to do the BAL, obtain a PCR and a galactomannan. Again, sensitivity is low and depends on the timing, but this really shows, and a really nice paper in BMT published in 2008, but really shows the importance of doing that early. The other thing to really walk through is to talk to your pulmonary colleagues to see if you can standardize the BAL procedures. What volume is instilled for BAL? How is the processing done? How are those materials transported to the lab? What's the time for turnaround? All of that to really standardize to try to increase the yield in the sampling error. We found one of the things that's really important is our pulmonary group uses what's called navigation bronchoscopy, and they found that over time where they thought they were within the pulmonary airways was not always exactly where they were when they used the navigation bronch system. That's traditionally used for biopsies. We've tried to get them to use that for BALs as well, though, and it seems like it's increased our diagnostic yield. So just some things to kind of think through and maybe talk with your pulmonary physicians about. Okay, and PCR, I mentioned PCR a little bit, so there's clearly some big advantages and some big disadvantages for that. So one of the big disadvantages to start with those is it's not widely available. This is a send-out test for most of us. We draw the blood or BAL here, and it's sent to a different hospital or different lab, so we don't get the results back in a viable manner. Often it's 2 to 3 day delay sometime. There's not a kit that's made that we can just order and do in-house within the United States. There is in Europe, and hopefully some other areas of the world too. The PCR test can find some resistance mutations. There's been a lot of talk and a lot of conversations about resistance with Aspergillus, and the PCR detects some of those, but not all. So phenotypic testing is still really needed if you're looking for resistance when you obtain an isolate. You can often obtain and diagnose to the species level, but sometimes there is a substantial delay depending on if it's really an unusual organism, an unusual Aspergillus species. Again, we use this in combination with our other tests, with galactomannan, with PCR. And then we've started to use cell-free DNA, and it seems to have a lower sensitivity, not always widely available, but a very high specificity. So sometimes if we just can't confirm the diagnosis, cell-free DNA, which is referred to at least in the cancer literature when used for that field as liquid biopsy, it has really helped us with some of these patients where we just seem to can't confirm the diagnosis. So hopefully that's available at your center. I'm very hopeful that this is going to be a platform we can just order and use on existing technology in the lab. And I think that's probably a year away. I think we're very hopeful that that's widely available globally. And then one of the other things to really emphasize is the radiologic course of pulmonary aspergillus. So I think we're used to seeing things like that first slide, a consolidation with a surrounding halo sign, but you really need to interpret that in the context of your patient's neutrophil count. So if you repeat imaging too early, even with effective therapy, if there's recovery of the neutrophil count, that consolidation is going to increase in size just with white hepatization occurring. So that's why the guidelines recommend not re-imaging for 14 days unless there's a clinical change. So with neutrophil recovery, that lesion is going to get bigger in size, and you can see that here in the middle when they've done this serial study. By day 3, that the consolidations increased by about 31%. And then later, once neutrophil recovery has occurred, that's when you start to see resolution of the halo, a decrease in size of the consolidation or mass lesion, and that's when the air crescent sign often develops. That's actually a favorable sign. It's very associated with neutrophil recovery. So when you look at these films, it's very important to interpret them in the context of your patient, your specific patient. If the size is getting bigger, it may be related to neutrophil recovery, and that can make it difficult to interpret the scan. So again, we typically don't recommend repeating imaging for 14 days after diagnosis for this reason. Again, there's lots of mimickers, and you can see here, we just saw one last week that looked exactly like an invasive mold infection, turned out to be an unusual species of Legionella on biopsy, Pseudomonas, other molds, non-Aspergillus molds, even Klebsiella, Nocardia, lymphoma, even CMV or cryptic can be mimickers for this. So again, halo signs suggestive of Aspergillus, but it can be due to other causes as well. So even if you see this and think you have the diagnosis, really try to confirm it with additional testing. Okay, so back to our patient, we did go ahead and perform a needle biopsy because that's a very peripheral lung lesion, and histopathology did say likely Aspergillus. It's acute angle branching hyphae. So we went ahead and did species identification and susceptibility testing for concern of the development of resistance. So global emergence of resistance has been seen all over the world. We've seen it in Western Europe and the United States, and certainly in China, India, other areas of Southeast Asia. And it's becoming a big problem. So itraconazole resistance was first noted a long time ago, even back in the 90s. But to use the analogy of HIV, there's very specific hotspots for mutations. So you can see this G54, L98, etc. They confer resistance to specific azoles. Some of them are pan-azole resistant, but some are just for one azole. So if you see resistance, it's important to probably check all of the available azoles to see if a different one is potentially susceptible. So it's very often something is posaconazole resistant, but can still be voriconazole susceptible. So really important to think through that. There's other mechanisms. There's efflux pumps, overexpression of the target enzyme. So a number of different mechanisms, which we won't cover today. There's just too many of them. But depending on where you practice, the azole resistance is more and more frequent. And so like in the Netherlands, about 20% of their Aspergillus is resistant before the patient's even seen the drug. It's just environmentally become resistant from the antifungals put down on their agricultural products. You can see here from past studies, and this study is a little bit dated now. So the last real resistance rate we have for China is somewhere between 2 to 11%. So again, really depends on your geographic region, but important to test the isolates you have to see how much resistance is in your location. But resistance continues to increase over time as we continue to see more and more of this disease. Okay, and then one last thing about this identification to the species level. So the leading causes of Aspergillus are still fumigatus, flavus, terreus, and niger, you can see in the top left here. But in transplant patients, particularly solid organ transplants and some of the bone marrow transplant population within the United States and a study that's been done in Spain are so-called cryptic Aspergillus species. So what are cryptic species? Cryptic species are ones that phenotypically under a microscope look like fumigatus or look like flavus, but when you do the sequencing of the isolate, it's actually a different species. The problem for this is things like lentulus and cladoeustis are innately resistant to azole, so it's really important to try to see exactly what you're treating in the care of these patients so you can put them on appropriate therapy. And this is why, so triazole resistance, again, most of this work has been done in the Netherlands. You can see this is a 5-year retrospective study. Triazole resistance in theirs was between 10 and 31% of all their Aspergillus fumigatus isolates. And you can see their outcomes really differ substantially between what they got up front as initial therapy. So if they had a resistant organism and got a drug that they're resistant to, those patients obviously did a lot worse. And that was a statistically significant value with a P of 0.017 at day 42. However, if you knew your local epidemiology and could tailor initial empiric therapy to that, the patients did much better. So again, really important to look for resistance in your specific population. Okay, and so just a few words on treatment. So the current IDSA guidelines list this here for invasive pulmonary, invasive aspergillosis. Voriconazole is the first-line therapy, and that's due to several different factors. It has really a long track record. It's been used for over 15 years for the treatment of Aspergillus. I think experience is really important. And then there's alternatives that have been listed, isavuconazole and posaconazole, but voriconazole is still recommended as first-line therapy for most patients. Alternatives include amphotericin B. There's a number of different formulations of amphotericin B. And then for deep salvage therapy, caspofungin or micafungin, etc. Combination therapy is not routinely recommended. That's a source of a lot of controversy. Some people really like to do combination therapy. So like inidilafungin plus voriconazole was the initial study, and a subgroup of those patients did better. So just some things to think through, but for most centers, they don't use combination therapy. Just to say a few more words about combination treatment, you can see here what that's based on. So this was voriconazole versus voriconazole plus anidulafungin and echinocandin. This was only hematologic malignancies and stem cell transplants. And their primary outcome was mortality at 6 weeks. And you can see here that p-values are very low, 0.08 and 0.07, but not significantly different. The group that was different, though, are those with probable disease. Those, again, those patients we typically see, patients with a mycologic factor plus a radiographic factor with a host factor. In that group, there was a small difference of 0.049 that did give it statistical significance. And this has been a big debate in the mycology community ever since this was published. Okay, I'm just going to say a few words on toxicity of the treatments. So we're going to go through the azoles here. Posaconazole and itraconazole both are associated with hypertension. So when you see these patients and they improve on treatment, you still need to follow them for side effects. This is largely a product of posaconazole, the extended release formulation. So blood levels went up, and with that, side effects went up. And we found this is sort of the cholesterol synthesis pathway. Posaconazole inhibits where this red X is. This is an 11-beta hydroxylase enzyme. It leads to a lot of 11-deoxycortisol. That's a potent mineralocorticoid. So these patients develop hypertension, and mostly with blood levels above 3. So it's important to follow levels. If your blood levels are above 4, they almost all develop hypertension. So important to really follow these patients over time. Voriconazole does have some side effects to be aware of. It can cause confusion with really high blood levels, so important to check blood levels in your patients. Hepatotoxicity for all azoles, not just voriconazole. And with high levels, sometimes patients will have these transient visual abnormalities. That is reversible. It's not permanent. It's not dangerous. It just means your drug levels are a little high. You need to back off on the dose. With really long-term use, like if you leave patients on this for years and years, it can cause photosensitivity, sunburn, and fluoride toxicity, but those are very rare side effects, but just things to be aware of because they typically are on board exams and those kind of things. Also, all the drugs in this class, of course, can cause QTc prolongation, something to think about for fluconazole, voriconazole, posaconazole. Isavuconazole actually can shorten the QTc, so just something to remember about that drug as well. And then lots of drug interactions. So talk to your pharmacists, be really cognizant of what other drugs you're putting your patients on because of these different drug interactions through the CYP enzyme process. Okay, and then just to wrap up, and the last couple of slides here to talk about breakthrough infections. This has become more and more important over the last few years. And you can see breakthrough. Again, these are patients who are on antifungals and then have an infection anyway. And this is a study that was done in North Carolina in the United States. And you can see the shift in epidemiology of fungal pathogens for patients on prophylaxis who developed an infection versus those who were not. So the top graph shows patients who were not already on antifungals and which fungal pathogens they developed infections with. The bottom shows those who had a breakthrough. If they were on prophylaxis and developed an infection anyway, you can see it's quite different. It's less Aspergillus, it's more mucorales, it's more molds, non-Aspergillus molds. So really important to look through, if they're on prophylaxis, think through your differential diagnosis a little bit more. When you approach these patients, not only is the epidemiology of the organism different, but you have to make sure the patient was compliant with their medication. Did they have interactions that had decreased your blood concentrations? Is it a resistant organism? Is it a sequestered site like a pleural effusion or the eye or CNS where you're going to have poor penetration? Or is it pseudo failure? And again, that's like the CAT scan when you see enlarging lesions despite recovery of the neutrophil count. So there's just some things to think through with breakthrough infections. How do you manage those? Again, prophylaxis is often done with posaconazole. If they break through with the yeast, you're going to put them on an echinocandin or amphotericin. If they break through with a mold infection, you're probably going to put them on a polyene followed by a different azole. So if they broke through posaconazole, you want to put them on voriconazole or a different azole. So try to change in class until you figure out exactly what's going on. So I'll stop here. I think I'm at the end of my time. It's really my pleasure. Thank you again to give this kind of broad, big picture view of invasive aspergillus. And I just thank you for the invitation and hope to talk with you later with questions.